All right, the next presentation is by Eric Daniels. He's the Chief Development Officer at Kiora Pharmaceuticals.
Great, wonderful. Thank you to the organizing committee for the opportunity to share a little bit of update on Kiora. We are a publicly traded company, so I encourage you to look at all of our disclosures and websites as I may be looking forward-looking statements. So for those of you who do know a little bit about Kiora, we're going to take a little bit of a pivot here. We are not a gene therapy story. We're not a gene therapy enterprise. We're developing two small molecules, one for vision restoration in IRDs, the second for retinal inflammation. And I'm going to talk about both programs today. So if you zoom out, both are actively in phase 2 studies and currently enrolling in both those in RP as well as in a basket study, which I'll explain a little bit later in the presentation. So let's talk a little bit about 301.
I want to make sure IT was aware the slides aren't showing.
They're showing here, so my apologies. While the slides come up, I'm happy to share a little bit about, fundamentally, let's talk about 301 and what makes it different from, a traditional gene therapy approach. So 301 is a photo switch molecule. It's a molecule that has the ability to change shape in response to light. And at the end of the day, while it sounds sort of Star Trek-y, we are ultimately doing ion channel modulation. We're able to stimulate the retinal ganglion cell, which we know survives in inherited retinal diseases, taking advantage of really the remaining retinal plasticity that exists. And we can stimulate that retinal ganglion cell to then ultimately send a signal to the brain. And this is preclinical work that's been going on for about 10 years, and we ultimately translated. Looks like we're back in line here. Slides aren't advancing.
They're not advancing on the main screen, but yes, on the side screen.
Oh, there we go. All right, forward-looking statements. Again, look at our SEC disclosures. You can see what I like for breakfast. You could probably find in there. Corporate highlights, again, two molecules that we're developing, small molecules, both one of which has been partnered. Zoom out here. These are our two active phase 2 studies that are enrolling. 301, as I was getting to. So this is ion channel modulation to stimulate the retinal ganglion cell. So where you have remaining viable RGCs that offer you the ability, as you can see in this molecule here, to change the shape in the presence of light, and 301 then no longer is blocking the ion pore, allowing activation of the retinal ganglion cell, thus sending a signal to the brain. This was first tested in a first-in-man study called Abacus 1. There were two groups of patients, really NLV and ultra-low vision patients. They were tested in one eye in several doses and then second eye in an escalating dose. We were really looking for any kind of non-random signal. We followed the patients for 30 days, and I will pause here just because there are a few major deviations, I guess, from where our last speakers were. One, we are a small molecule approach delivered by IVT, standard IVT. Number two, we are not in the business of disease modification. We're vision restoring. So we do anticipate multiple injections over time in future subjects. And when we look at the compendium of data, we looked at both kinetic visual field. We saw an improvement on functional testing, on an improvement in visual acuity, as well as in PROMs. And what you'll notice in all of these really are this trend over 30 days of an improvement and then a waning. This is very much in line with the kinetics of the molecule. So again, very consistent with what we expected to see given the half-life. Now, we also wanted to see were any of these signals in fact going to the brain, and so we did functional MR to look, and we saw as well an improvement in signal at both day 2 and day 14, again waning at day 29, consistent again with the small molecule approach and the kinetics of the molecule. So our key takeaways were we were safe, we had proof of concept, we had a reason to believe, and we were moving on to our phase 2 study, which is now actively enrolling, known as Abacus 2. It's a multiple dose, bilateral injection, double mask, 36 patient study. It is a 2-to-1 randomization of patients who have a diagnosis of RP. It is mutation agnostic, like Dr. Barone's approach and the nanoscope approach. It is 3 IVT injections every 6 weeks, and this study has started, and we follow these patients out subsequently for a period of 3 months. For the sake of time, moving on to KIO-104, our second asset that's in development, a small molecule DHODH inhibitor, just to take you back to biochemistry. DHODH is an enzyme that sits in the mitochondria, and it's really responsible for the generation of pyrimidines, the sort of, nucleotide soup you need to both make T cells, not only proliferate them, but also cause them to activate and behave in the way that they do. So by starving the pyrimidines, you are in essence choking the T cell population as well as their productivity or their function. In a first-in-man study, this was taken and looked at in patients with CME as well. This is actually in patients in uveitis. There was an improvement in CME as well as an improvement in visual acuity at the 1.2 microgram dose. We've then taken this proof of concept data and are now enrolling the Clarity study. This is really, as mentioned before, this sort of basket study where we've got a number of different indications promoting or causing macular edema. And we have, first part of the study is to really identify the appropriate dose, and then the second part is an expansion cohort where we'll look at biweekly injection or monthly injection, looking for a steroid-sparing approach to treat retinal inflammation. So with that, sorry for the technical hiccup, and if anyone has any questions, I appreciate it. Please reach out, and thank you for your time.